Pre-health shadowing is a student organization, student-led, student-based, with the goals of creating flexible and accessible learning opportunities for students everywhere. I'm really excited to welcome you guys all today to our 16th virtual shadowing session with Michele Neskey, who is a PA with her focus in oncology. So welcome. We're honored to have you here today.
Thank you so much for having me. Like I said before you guys got on, this is a great idea and a great opportunity. So really excited to be here and talk to you guys all over the country. I just saw so many, and even in Puerto Rico and Hawaii, like, oh my God. Hello, everybody. So I won't take up too much of your evening, but I'll talk a little bit about today, my role as a PA, specifically in oncology, a little bit about my day, how that normally rolls. And then at the end, we'll do a Q&A. First of all, my name is Michele Neskey. I've been a physician assistant for 15 years. I graduated from the Yale PA program in 2005. In the in-person program, they do have a sort of hybrid program now. They did not have that when I was there. And so I have been a PA for 15 years. I started out in internal medicine and then transitioned to oncology in my second year of being a PA, and I have been in oncology ever since. I've moved 3 separate times. My husband happens to be a surgeon. He is a ear, nose, and throat board certified ENT, but he does only head and neck cancer surgery. So he does head and neck surgical oncology, which is interesting. And by the way, I did it oncology first. Okay, totally copied me, but I'm just saying. And then, so he's definitely on the surgical end. I'm definitely more a medical person. And then, so I've lived in Miami, Texas, Houston, Texas, and now Charleston, South Carolina. I'm actually originally from Jersey, New Jersey. I went to school at the University of Connecticut, then Yale. I lived in Boston for a while. And then, so I've been kind of all over. But basically, just a little bit about my background, because some people ask me how I decided to go PA. I actually was an undergraduate major in genetics. I did not decide to be a PA until until a year and a half after I graduated college. And so I had to go back to take some classes and things like that, but definitely doable and get some patient care experience. So I was a genetics major. I worked in a basic science research lab, decided that that was definitely not for me. Went and shadowed the physician, loved it, thought I was on the wrong side of medicine. Went back, took a couple classes, got certified as a CNA, got some patient care hours, did a bunch of other stuff, and then applied. So I graduated PA school when I was 20, I don't know, 26, 27, something like that. And then I've been working ever since. So that's kind of just a very brief version of my backstory. And then, so just to kind of take you guys through, I didn't know that I wanted to do oncology. I actually kind of fell into it a little bit, and I had been doing basic science research in cancer. And so when I went to PA school, I did do an oncology rotation in PA school, and I actually did not like it like at all. And I think a lot of it had to do with the preceptor, the setting, they're not always perfect, right? And so I think a lot of it had to do that with that. And so I didn't always know that I wanted to do oncology, but once I started doing it, I honestly couldn't really see myself doing anything else. I truly enjoy it. I've worked in a bunch of different practice settings. So first I worked in a community oncology practice where we saw everything. So hematology, everything from benign hematology, leukemia, lymphoma, to breast cancer, colon cancer, lung cancer, all that kind of stuff. When I moved to MD Anderson, it was highly specialized, high volume. I did thoracic, head and neck, medical oncology, so chemotherapy, immunotherapy, things like that. So no surgical aspect for me. And I did only lung cancer and only head and neck cancer, and in adults. And then when I moved here to Charleston, I sort of still do mostly lung cancer, but I have worked in almost every solid tumor since being here. So I've been in GI, lung, head and neck, melanoma, phase 1. So got a big gamma, even breast cancer more recently. So got a nice overview of solid tumor medical oncology. So when I tell you about my day, you'll see that I'm mostly taking care of adult patients. I currently only do outpatient work, which means I'm only in the clinic. I do not round in the hospital. I used to do that when I was in community oncology practice and even at MD Anderson, but this position is strictly outpatient, which I actually prefer and love. So without further ado and all my jabbering, let me get you my presentation. So I know you guys can probably see this. Let me see if I can put it on present mode.
And students, feel free to drop questions in the chat at any point during the presentation. Our team will be recording all of the questions and make sure that they get asked during the Q&A portion.
Yeah, awesome. So, okay, so basically, as I said, I do outpatient medical oncology. So I see a template of patients from 8:30 to 5 with appointments every 20 minutes. A template is a schedule. So they basically schedule patients every 20 minutes, in my slots from 8:30 to 5. I do see new patients as needed with the attending physicians. I manage patients' infusion reactions so that after they see me and they go get their treatment, if they have an allergic reaction or chest pain or any problem that they're having during their infusion, I will go over there and manage that. I see solid tumor oncology patients undergoing therapy or on surveillance. I run an independent template from my physicians. So you will see this done a lot of different ways with PAs. Some do what they call a shared template or a shared visit where the PA and the physician have one schedule and they kind of work off the same, whereas others have their own specific schedule. So I have my own schedule and the doctors have their own schedules. And there is only one day of the week that I actually am in the clinic with them, which is Tuesdays. The other days I am by myself. So they are around. And when I mean by myself, I just mean they don't have clinic there that day. They may be elsewhere or doing research or doing whatever, but they're not physically in the clinic. And then I have shared nursing support, which my nurses are fantastic. So I can't really complain. So a day with me. So here's my handle on Instagram. Most of you have found me there. I'm Michele at the Posh PA. So pre-COVID, I think I posted this in my reels yesterday. I had done a video of what my day is normally like, and this is pretty clear. So I used to get up 5:30. Now I get up at 6. So I get up at 6, work out, and then I get myself ready for the day. I have a 6-year-old daughter. And I have to take her to school. And I picked a school that's right across the street from my job. So I basically get ready and take her with me. We are in the car at 7:30, 7:40. I drop her off and then I usually sit in my car and either get on my IG and give you guys a hello, or I meditate for 5 minutes or listen to my favorite podcast. And then at 8:30, I start my first patient. Again, 4:30 is usually when the last patient is scheduled. I leave somewhere around 5:30 or 6, only if all my documentation is done. So I like to do all my charting before I go home. I just don't like to leave it, although I did leave one note today. Okay, so I did a video. It's kind of choppy and I sound like I'm out of breath. I'm not really sure why, but I was trying to do this like without my mask on and people thinking I was weird in the clinic. So here's a little bit of that office tour.
Hey guys, about to take you on a brief tour of my office. Nothing fancy, but here we are. Okay, normal patient room. There we go. This is the patient's hallway. And then we walk out into the provider workspace, which is here. So basically I see patients in here that are on therapy and I review, there's a computer in the room, so I review scans with them. And we go over everything they need. I treat their side effects and everything like that. So that's just a basic overview of my office, since you can't be here with me in person. Okay, now I'll take you right across the hallway to where our patients get treated in the infusion center. Right here we go. So I can't flip this video. Due to HIPAA reasons, I will not take you guys. Right, wave at us, wave at us.
So that's basically the setup. Okay, so patients will come in. So this is how the clinic flows. So basically I work at a cancer center. In the cancer center on the first floor, when you walk in, you check in. There is on the first floor, there's a pharmacy, there's radiation oncology, there's a cafe, and there is conference room space, also an outdoor like garden healing area, and like kind of administrative offices. On the second floor, there is a phlebotomy lab where patients get their labs drawn, or if they have a port, they'll go to the infusion center and have it drawn there. So we have all of that in-house. The clinics are all on the second floor and on the third floor. There is a mammography suite on the third floor as well, where they do mammograms and ultrasounds. And then on the second floor, you will also find the infusion center. So when the patients come up to the second floor, they typically check in, go get their blood work, come back, get triaged by a medical assistant, get put into the patient's room. You see the patients see the provider, they check out, get their next appointments, and then they head to the infusion suite. So it's like all on one floor, which is kind of nice. And if there's a reaction or whatever, I can just kind of zoom across the hall. And so basically, this is how the clinic flow goes. So they see the provider and then they're sent for infusion, or if they need additional tests, or they go home. So a bulk of my job is assessing, managing symptoms, prescribing medications for side effects, adjusting medication doses, and a lot of patient education, not only on their cancer, but on their treatment and what to expect, setting expectations and goals for patients' care. I love going over CAT scans, like love it. So I usually will discuss results of imaging studies and show the patients their films if they want to see them, and talk about continuing treatment if everything's great, or if we need to make a change or something like that. So I provide chemotherapy, immunotherapy, and biologics teaching. These are just all different types of treatments for cancer. I sign consent forms and I can sign chemotherapy orders after the first cycle. I communicate with nurses constantly, as well as all of the other oncology subspecialties. So I'm always calling radiation oncology, radiology, pathology, and our nurse navigator, who's super helpful. I manage electrolyte abnormalities. I send patients for scans if I think they need to be scanned. I see urgent care kind of visits, so we can keep people out of the hospital as much as possible. And so it's really kind of the gamut. Every day is always a little bit different, and which is what I like about it. So before I get into patients, before I get into a case, the one thing I want to be clear about is if you understand what medical versus surgical versus radiation oncology is. So medical oncology is basically the oncology specialty where we use treatments that are going to circulate throughout the entire body to treat the cancer, whether that's an oral drug or whether that's an IV chemotherapy or some of these newer drugs, which are called immunotherapy drugs. And so we are basically providing medical treatment, whereas surgical oncologists are doing any type of surgical resections or any procedures that we'll need to sort of make diagnoses or even treat cancers, radiation as well. So cancer care is very multidisciplinary. We have tumor boards every single week for like every cancer site. So there's a thoracic tumor board, so like a chest tumor board, there's a head and neck tumor board, there's a breast tumor board. And so everybody gets together and talks about cases and what we feel is the best management, which is a really awesome part of oncology, because we're constantly utilizing our colleagues and resources and making sure that we're doing everything we can and the best thing we can for our patients. So this is actually a 29-year-old woman who is one of my current patients. She presented with a cough and wheezing to her primary care in May. So that was sort of right after Corona. Wasn't too bad here in South Carolina yet. She was treated with antibiotics and prednisone. She didn't have good relief. Her symptoms got worse, and she developed some right-sided chest pain. No cancer history, previous breast biopsy negative for cancer. So she's adopted and was not aware of her full family history. And so her maternal grandmother had breast cancer, and her mother may have had cancer, but she didn't know its kind. So she had a CT chest, and it showed sort of an abrupt termination of the right upper lobe bronchus. So that's the main windpipe going into the right portion of your upper portion of your lung. Sorry. And a lot of nodules. So a lot of masses in both lungs, as well as lymph nodes in the center portion of her chest, which were very concerning for a mass. She had a bronchoscopy. So a bronchoscopy is a procedure in which they go down through your nose into your airway, and down, or through your mouth into your airway, and this was an endobronchial ultrasound, but you can take a scope, just like they do an endoscopy for your esophagus. They basically go into your airway. So they go into your airway, they look in the airway, they can do an inspection. There's a camera, you can see it up on a big screen. You can look for any masses, you can look for any problems with the airway. Or you can do an EBUS, which is an endobronchial ultrasound. So they take basically an ultrasound probe, attach it to the camera, and they go down and they ultrasound through your airway, lymph nodes that are in the center portion of your chest. And they took a biopsy that way. It's a really nice way to take a biopsy because it's minimally invasive. So it was positive for lung cancer. There are two main types of lung cancer: non-small cell lung cancer and small cell lung cancer, both treated differently. So it's important to know the difference. She has non-small cell lung cancer. The most common type of non-small cell lung cancer is adenocarcinoma, followed by squamous cell carcinoma.
Y'all home in bed chilling. I'm still here doing paperwork.
So she has what we call a non-small cell lung cancer. The rest of her CTs, chest, abdomen, pelvis, did not show anything concerning outside of her lungs. She had a PET scan. A PET scan is a nuclear medicine study that uses a sugar-based dye instead of iodine contrast, and it covers the skull base to the mid-thigh. So basically get your whole body. And we use this for staging cancer that is maybe outside of the chest or somewhere else that we're not really seeing. And so what the sugar does is any cells that are metabolically active and turning over a lot, like infectious cells or cancer cells or inflammation, they light up like yellow on this study. So it's called a PET scan. And so hypermetabolic just means it was really glowing, which basically told us this was a giant cancer with lymph nodes in the center portion of her chest. And she also had a lot of nodules in both lungs. So that automatically made her a stage 4. So anytime that you have a lung cancer that has spread outside of one portion of the lung or even into the lymph nodes to the other lung, that is a stage 4, or if it spreads to other parts of the body. And so there was concern here that she might have had a cervical spine lesion as well. She also had some thyroid nodules, but those were not lung cancer. They were a separate issue. This is what a PET scan looks like. So this right here, the sagittal view, you can see kind of the anatomy here a little bit. I can't scroll through because it's a static image, but usually you can kind of scroll through all these images. And you could see right up here at the top of her right lung is this big yellow blob, right? So there are certain things that always light up on a PET scan because they're always active. Your bladder, your kidneys, your brain, and your heart, and your ureters. Typically, those things are normal and they should be yellow. The things that should not be yellow are things that look like this, where the other side you see is completely clear. And then on this axial image, you can really see this big mass here, very, very close to the airway, causing collapse of her right upper lung. So staging of cancer is always done in a tumor node metastasis way for solid tumors. T is for tumor, N is for node, M is for metastasis. Literally, the system is different for every single cancer. So, I've stopped memorizing these things because every time I finally get it, it changes or updates. But basically, tumor size, lymph nodes, how many and where, and metastasis, where has it spread? And so in her case, while her tumor itself wasn't that big, she had a lot of lymph nodes in the center portion of her chest, and obviously nodules in both lungs that were cancerous. So that automatically makes her a stage 4. So basically, the patient underwent palliative radiation to the right upper neck. So what does that mean? Palliative radiation means that it is not curative. It's just to help treat an area that can cause opening of the lung and shrink the tumor a little bit once we get ready to go into another treatment. This testing is really just about looking at specific markers within the tumor that can help us pick which treatment will be best for her. And so this is called kind of molecular testing or genomic testing, or you may hear it as something like genomics, that kind of stuff, where you literally send a piece of the tumor out for all these different tests. Why? Because these are mutations, EGFR, ALK, ROS, and PD-L1. PD-L1 is not a mutation, but these are genetic alterations within the cancer itself. And if you have one of these, there are pills that actually target them, turn them off, and stop the cancer from growing. So that's what a biologic is, and that's what it's called, targeted therapy. There's like 10 to 15% of lung cancer patients will have one of these, particularly those who have never smoked or have a light smoking history, so less than 100 cigarettes in their lifetime. We test a PD-L1 because that is a stain, that's a protein that tells us whether or not a patient will respond to immunotherapy like Keytruda or Opdivo or someplace like that, or some drugs like that you see on television. Patients with over 50% in lung cancer respond really well, but that doesn't mean if you have 0 that you won't respond. So it's just kind of a helpful tool, but we still can give you the treatment even if you have 0. So with this profile, she gets recommended to have chemotherapy plus immunotherapy. So chemotherapy plus immunotherapy together, just 3 drugs given in an IV once every 3 weeks. So on day 1, I'm paged to the infusion center when she goes to get her treatment. 2 minutes after receiving a nausea medicine, she became flushed. She had chest tightness and oxygen saturation of 85%. She was hypertensive to 160. So basically, when they're over there in the infusion center, when you're getting a treatment like this, the first couple of drugs that you get in the IV are nausea medicines, a nausea medication to prevent nausea and delayed nausea, steroids, and things like that. And so in my 15 years as a PA, I have never seen anyone react to a nausea medicine like this. She was basically having a significant allergic reaction. So we gave her Benadryl, we gave her steroids, we gave her Pepcid, and she began to recover very quickly. After about 10 minutes, the whole thing happened again, even though we had never re-administered the drug. So we gave her more steroids, more oxygen, and after about an hour, she stabilized. So we did this all in the infusion center so that we didn't have to send her to the hospital. So we stopped that drug. We put it on her allergy list. We're obviously never going to give that to her again. We were able to give her the chemotherapy without an issue, but we couldn't give her the immunotherapy. Why? So we had to do a little bit of investigating. So 2 weeks later, before this. So why couldn't we give her the immunotherapy? It turns out that these medicines, when they're given in an IV, are mixed with solvents, basically, that make them deliverable. And this nausea medicine that she had is mixed with it's like polysorbate 80 or something. And we don't know if she reacted to the drug itself or to the polysorbate 80. So the other chemo drugs that she got were not mixed with that solvent. The immunotherapy is mixed with that solvent, polysorbate 80. So we could not take the chance of giving her a drug mixed with that solvent and having another reaction like this. That would probably have sent her to the hospital. So that's like detective work. So you need your pharmacists, you need, lots of people involved and helping with that. So she gets her treatment. 2 weeks later, she comes. She cannot swallow. So she was unable to tolerate liquids or solids. No white patches on the back of her throat. So no fungal infections or thrush. No recent infections. She had some itching of the ear. She had some dysuria, things like that. But the most important thing was she couldn't even swallow like water. She hadn't eaten anything significant. So I examined her, really red in the posterior pharynx, so the back of the throat. She had some redness in her ear. The rest of her exam was normal. Her UA looked like she might have a urinary infection. So what do I do? So dysphagia, so odynophagia, which is painful swallowing, or dysphagia, not being able to swallow, secondary to inflammation of the esophagus. It was related to her recent radiation. Remember I said where she had radiation to that lung mass to help open up her lung? Well, radiation are external beams, and some of the beams will hit your esophagus because it's very close to the center portion. And so she couldn't swallow because she had inflammation in her esophagus related to the radiation therapy. And so to try to keep her out of the hospital and get her nutrition and things like that, I gave her some different medications, Carafate, which kind of coats the esophagus, numbing medication, IV fluids in the infusion center, liquids, Jello, Boost, Ensure. I gave her, and then on top of that, she had like otitis externa, so she had an outer ear infection and a UTI. So there's always different things when these patients come in. It's never one clear shot, almost never. And so it's really important to be able to realize that not everything is going to be related to the chemotherapy, but could be related to their other treatments. It could be related to their current treatment. Esophagitis is basically inflammation of the esophagus after radiation to the chest, and actually could be exacerbated by chemotherapy. They always feel like the food gets stuck. It hurts when I swallow. I can't swallow. We treat that with pain medicine, antacids, supportive care, and a feeding tube. If needed, particularly in those getting radiation to the head and neck, they almost always get a feeding tube. The other thing is this doesn't happen right away. Okay. So it happens after. So it usually happens about 2 weeks after they finish radiation, and then starts to improve after that. So it's really important to set expectations for these patients on what's going to happen to them, because they're like, woohoo, done, I'm good. And then all of a sudden they have pain, right? So it's important to set those expectations up front. So what are the takeaways? That cancer care is multidisciplinary and requires constant communication. Now, during this patient's infusion reaction, the physician was involved, after I saw her, all of that. And I'm always communicating with them, but they're not necessarily there. But when I need them, they are. So cancer care is multidisciplinary, constant communication with other specialties and nurses. Infusion nurses are amazing. They take care of a lot of these reactions as they come along. They have protocols in place. Really trying to think critically when patients have acute symptoms to keep them out of the hospital if positive. At the end of the day, I make sure the attending knows any important changes in the care of their patient. And education and teaching is a large component of my job, as well as advocacy and symptom management. So while I function very independently, I'm always aware of my role, and I always know when to ask for help and when I'm in over my head. And I also really try to take ownership of these patients as if, they're not the doctors, they're mine too. And so we take care of them together. And that's from my other presentation. So that kind of sums up my presentation at this point. I know I went through a lot. I did a lot of different, things, when it comes to talking about cancer and things like that. So just making sure that giving you guys a little bit of education on top of what I just do every day. But, I think the most important takeaways are that you never know what's going to come in the door, and to be prepared. There's a lot of internal medicine involved in cancer care. And we always talk to the other specialists a lot and try to get them in to see the other specialists a lot. I did not know this stuff when I left PA school. The learning curve was fairly large. And so it really took time to feel comfortable and get to know all these things. And, now it's like second nature. So I think I'll end there and let you guys take some questions.
Great, awesome. So we're going to go ahead and get started with our Q&A portion of this session. So students feel free, my presentation's still loading here. Students feel free to type in the chat if you have any questions. We'll also be taking questions orally if you would like to directly speak. Please utilize the raise your hand function on the participants, and we'll just go based off of that. So the first question that we have for you is, do you ever work with your husband?
No, well, yes. I did actually for a while, not directly. So we shared patients, and there are some occasional patients that we still share. I've never worked side by side with him in a clinic because I don't do the surgical part. Nor do I really want to work with him. Like, I want to remain married. But there was a lot of patients that I would share with him, particularly when I was doing head and neck. So they would go to him for the surgery, and then they would come to me and the doc for chemo and radiation. And so they would sort of see both of us. And so that was kind of interesting and fun. And, we'd be at the same tumor boards and things like that. But since I've moved away from head and neck more, we don't share as many patients, but I know how to get somebody into ENT ASAP. So it is helpful to have an inside line, I will say.
All right, great. Our first question will be asked by Claire. Go ahead.
Okay.
Hi, Michelle. Doing this. I have a question about oncology research. So I actually work at a cancer center doing phase 1 research with cancer patients, and I'm also pre-PA, and I want to eventually be a PA with oncology clinical research, but I don't know any PAs at all in research, and I'm wondering if you ever work with any, or if you have any kind of opportunities to work with research studies in patients.
I totally left that out of my presentation, but that is a huge portion of my job. I work very closely with our research coordinators. We put patients on clinical trials as much as we can because, they can get new and innovative drugs for their cancers that they wouldn't be able to get off study. So my role as a PA in clinical research in a clinical practice is that I will see patients, screen them for clinical trials. I can enroll and sign consent for clinical trials. I can see patients during their treatment visits. I can sign their orders. I can basically do all the things, and I serve as a sub-investigator. And so if the trial is initiated by one of the doctors that I worked with. So we have a couple of physicians that do like investigator initiated trials or whatever. If it gets published, I'll be on the trial because I took care of patients in there. You can take a more active role depending on your institution. So right now we have a small research group with a lot of clinical trial coordinators, and they do the brunt of the work, but I'm constantly, the clinical trial coordinator stands next to me. She happens to be pre-med. She stands next to me like every Tuesday in clinic and, going through patients like that. So there's definitely opportunity there to be involved from the clinical standpoint in terms of publications and things like that too. You can get more involved depending on what you want to do.
Awesome. Thank you so much. Our next question is going to be asked by Ira. Go ahead.
Hi. So I'm interested in becoming a pediatric oncology nurse, and I was wondering how close the oncology nurses work with you in the infusion center.
Oh, they're like, as close as you can get. And they do a lot of work. So they do a lot of teaching with the patients as well as it depends. So like we have clinic oncology nurses and then we have infusion oncology nurses, and their roles are very different. So the nurses in the infusion center give the drugs. So they give the chemotherapy, they administer it, they access the ports, they do everything. And they give education, they put on like auto injectors on people. I mean, they do all that. The nurses in the clinic give a lot of injections. I order them, they give them. I mean, they're very heavily involved with the providers and their patients, and usually the most important link between the patients and the providers.
Thank you for that. The next question that we have in the chat is, you said that during PA school, you didn't really like oncology as much. Was there a different specialty that you wanted to go into?
No, a lot of people that I went to PA school with were like, I'm going to be an ortho PA. I came here to be an ortho PA, and they became an ortho PA. I never had that specific goal in mind. And that's partly the reason why I went PA, because I was like, I don't know what I want to, like, there's nothing specific that I'm like, oh my God, I have to do that, and partly because I didn't know what it was like to be in a lot of those fields, or if I would like it. And I just didn't want to commit. So I felt like if I was a PA, that I could have the option to move, not knowing that eventually I would find something that I would stay into for 15 years. So I knew that I was more of a medicine person than a surgical person. And I think that's more of that's a more important decision to make early on, rather than, oh, I want to do this, this, and that. So I also know a lot of medical students and a lot of, doctors that changed what they wanted to do when they went in, wanted to be plastic surgery, turned out psych, you know what I mean? So it's just important to keep an open mind when you're going through this process.
Thank you. The next question that we have is, what made you like outpatient more than inpatient?
Yeah. So inpatient, it's not that I don't like inpatient, it's just very different. I feel like in the outpatient setting, you get a lot more interaction and relationship with the patients. And in the hospital, they are acutely ill. And so it's a very different goal. So when they're in the hospital, the goal is to take care of them and do your best to get them out of the hospital. And sometimes they're very sick. Sometimes they never come out of the hospital. So it can be very challenging. But to me, on a solid tumor side, it was more relationship building on the outpatient setting. When you're talking about like hematology, bone marrow transplant, I think the inpatient people would tell you a different story, because those patients are in there for a long time. And I think that the patients and the providers on the inpatient service will develop a stronger inpatient, relationship with their providers. I don't do that. So I'm not going to speak to that. But for me personally, I feel like, the outpatient setting is just more comfortable for me. I feel more comfortable there. It's not so acute, and ordering IVs and, all that stuff all the time. But it's my job really in the outpatient is to try and keep them out of the hospital by utilizing the infusion center and resources and things like that.
Thank you for that. The next question will be asked by Jessica. Can you unmute yourself?
Yes, hello. Hi. Thank you so much for your time to start off.
Yeah.
I'm a university junior right now, and so I'm looking into getting that hands-on experience, the clinical hours, and I was wondering which type of clinical experience most closely resembles the PA path, so like EMT or the MA or something like that.
That's hard because I don't know that, there are some medical assistant jobs where I feel like you're doing a lot of hands-on stuff, assisting with procedures, that kind of thing. But the role is so different when you make a transition, because you're making, more complex medical decisions. EMT, I think, would be or a paramedic. I mean, those are going to be closer, right? Particularly for an ER type setting. But I really feel like any patient care experience, whether I was a CNA, I mean, talk about, I mean, I still gained valuable lessons from that and skills from that I still use today. So I think that, even if you can't closely resemble what you might do, it's good to get that experience talking to patients, communicating with team members. Learning how to talk to patients is harder than you think. And so just really any experience like that is good.
Thank you for that. The next question in the chat is, what is the process like in regards to switching licensing when moving to different states as a PA?
So you have a national certification, so you don't have to like retake an exam, but you have to get a state license. So you have to apply, you have to pay the money, and you basically have to you have to fill out a lot of paperwork, and usually provide them with a copy of your national certification and all this stuff, get letters of recommendation. So it's really just paperwork. And there are a few states that require you to take an exam, like about the laws in their state. Like I had to take one in Texas, whereas others, you don't have to do any of that. And so really, it's not that difficult. It's just tedious paperwork, and it takes a little bit of time, but it's completely doable. I mean, it takes, I would say, 8 to 12 weeks to get a license in a state.
Thank you. Next question is, do you have any advice to boost self-confidence and reassurance when applying to different programs?
Yeah, I mean, so, I really tell people this all the time, and I feel like it's kind of cheesy, but at the same time, it's really quite true. It's that whenever you start to look and think, oh, this isn't going to happen for me, or, oh, what am I doing? You really have to think about why you're doing it. And so I always really tell people to write down why. Like, why do you want to be in medicine? Like, why? Do you have an inherent desire to help other people, make people feel better? Do you want to make an impact on a certain community? Do you love and are fascinated by medicine and treatments and things like that? Are you somebody that really is so has such precision and dexterity in the thought of surgery and being able to remove things and help people, and identifies with get super specific, not oh, I just want to help people. No, because you wouldn't even be thinking about medicine if you didn't want to help people. Why do you want to do it? Because when you think about why you want to do it, you're going to be like, you know what? Shut out all these stupid negative feelings, and I'm going to do this no matter what. The other thing is, and you probably see people saying this all the time, is that you have to stay in your lane. Stop looking at what everybody else is doing. The minute you do that, you're going to go into a complete mind spiral. and it's going to get really, really challenging. So focus on what you're doing. Put positive energy into the universe. Give yourself a daily mantra that this is what you are going to do, and this is how you are going to do it. And you put it on your mirror and you say it every morning, because if you put that energy in the universe, I promise you it will happen. And so I would say those are the best 3 things that you could do.
Thank you for that. The next question will be asked by Emily.
Hi. So my question is, I don't know, if you're at a big, or you have a lot of experience at a big academic medical center or anything like that. But how much do you do teaching? Do you teach residents? Do you do precepting with other PA students, or with nursing students, or anything like that?
Yes. So yes and yes. So I'm currently at a mid-sized academic center. When I was in Texas, that was a huge academic medical center. At both places, I took students, so PA students, NP students, whatever, to do precepting. Before COVID, I would do shadowing, for anybody who wanted to do it. By the way, that dog is adorbs. And then, I would say, when I was at the bigger academic center, I got involved with creating an online course for nurse practitioners and PAs new to oncology. I developed a cancer therapeutics like CME series, for them. And then currently I will teach at the PA program as a guest lecturer, usually during their HEMONC block. I'll do that. I was taking students up until COVID, and as a preceptor, and so yes, to answer your question, I'm able to do a lot of different things. I also was the lead. So when I was in Texas, I was the supervisor of 13 NPs and PAs. And then here in Charleston, I was the lead of our lead APP for 2 years. And then I stepped down to do more APP council kind of work for the hospital. And now I'm a manager of professional development and wellness for the Advanced Practitioner Best Practice Center.
The next question that we have in the chat is, did you take a fellowship or supplemental schooling to become an oncology PA?
No, you do not have to. They do exist, but you do not need to do them. So if you want to, they're wonderful. MD Anderson has one. I think Mayo has one. I mean, they're excellent. I do think that they provide a good, solid foundation on which to get a job and that kind of thing. With that being said, my personal opinion, if you find a practice that's willing to train you, you do not need it. So but they're great. You just don't have to do that.
Thank you. The next question will be asked by Monica.
Hello.
Hi.
Hi. I was wondering, what differences do you notice between both yourself and your husband, like professionally in your personal lives and also in terms of finances?
I love that. Okay. My husband and I, while we both love medicine, are quite different individuals. Dave has, throughout his entire training, his number one priority was his career. And, he made that very clear that, I'm his partner in crime, but like his career, was the number one priority. And when you are dating someone like that, or you're married to someone like that, it can be challenging, because he was like, this is what I'm going to be. I want this success. This is how I'm going to do it. And there was very little leeway, in his mind, as to how that pathway was going to play out. Whereas I was like, well, why don't you just do this? This is easier. We can do this, and that was just not, so I feel like I have more of an open mind, and he is very detailed. He's very specific. He's extremely focused. And, that was hard, on our marriage for a little while. Because I felt like maybe I was making more sacrifices, than he was, moving multiple times and, doing all of this stuff. At the same time, when I wanted him to do the path that he wanted to do so that he never had any regrets, I didn't want to be the person that was like, you have to do this, or never gave him any ultimatums or anything. So during the training time, it was challenging. But I will say that, once we got to our final destination and we settled in here and stuff, and he's been practicing as an attending, it's been very interesting, because I've been practicing for so long and he has only been practicing for 6 years, that he is now going through some of the things I went through when I was at that point. And so it's really nice to be able to be like, hey, I was like this is what I did. And, I think that for so long, he was so focused on success and getting where he needed to be. And then he was at where he needed to be. And he's like, why am I not happy? Why am I not happy? Right? Because it's always the next thing is going to be the thing. Right. So I think it's the two of us have really kind of taken hold of what it means for us to be happy in our professional lives and creating a balance with our home life. and finding the things that bring us joy outside of medicine, hobbies, friends, things like that, that maybe we put on the back burner for a really long time. I have better work-life balance than him, hands down, but I also created that. So I worked full-time for a really long time, and now I work part-time because we have a 6-year-old. So, I work part-time. I work 3 days a week. I do my business from home so that I can still work full-time, half-time at my job, half-time here, make a good income, and be more available for my daughter. He's on call more often. I'm not on call. He goes into the hospital at 9:00 at night for random reasons. I never do that. So, I think that there are a lot of differences from that standpoint. As far as financial, he definitely makes more money, hands down, but he trained for so long that we have so much freaking debt. So it's not, we're actually very lucky. We don't have a lot of debt. But at the same time, when you have basically a single income household for a long time, that's paying for a lot of the stuff, you gain debt, even though it's not necessarily loan debt. And so while he makes a lot more money than I do, it sort of balances a little bit over time. Obviously it separates out, and financially, we can't live in this house without his salary. You know what I mean? So, but he better earn it, man. He's been training for 10 years, get a job. So I feel but at the same time, to be very, very fair, the financial piece is quite different depending on where you work and what state. So whether you're in private practice, whether you're in academia always pays less. And I only work part-time right now. So, my income is less from that, although I have my business now that I supplement. So from that standpoint, things are definitely a little bit different.
I heard you talk a little bit about your work-life balance. Could you talk a little bit more about that, and what does it mean, and how do you go about navigating that?
Yeah, so work-life balance is a constant process. It's never perfect, and ever since I started my business on top of it, it's definitely been harder than I anticipated. I think that with COVID, it was insane, because to me, what's important to me is that when I'm at work, I do a really good job, and that I really care for my patients, and that I do everything I can for them. But when I leave that, I want to leave it. And it's hard to do that for a really long time when you're a clinician. So it's really easy to go home and check labs and get everything's on your phone. You get the app, you can get in, look at your patient charts. You got to cut it off. You have to say, I'm done now. And that's the part that I find Dave struggles with a lot more, because he's the doctor and he's constantly getting texts from fellows, residents, all that kind of stuff. Where for me, yeah, maybe I get a text or two on my days off from the nurses and stuff like that, but it's way more manageable, and I set my boundaries. I think being at home, it's easier for me to set boundaries with my work at the hospital than it is for me in my business, because my business is virtual and I can constantly be answering emails and all that stuff. So again, I've really had to learn how to set specific time that I'm going to work on the business. I'm going to see my pre-PA clients. I'm going to help this many people. I'm going to commit to shadowing events. I'm going to do this. I can't do everything for everybody and still be, happy and healthy and a good mom. So it's definitely a work in progress. But what's most important to me, that when I leave this earth, is, not that I'm famous, or that, is that I was a good person, a good mom, and I helped everybody that I could. And, if I remind myself of that, and my goals are to, what my goals are, and that is to be an example for my daughter, be an example for people who want to be PAs or in the medical field, take really good care of the people I can through their cancer journey, and be that genuine person. And so I really try to focus on that when I can. And it's hard. I'm a fixer and I'm a giver. Like I tend to give a lot and don't take a lot. And I also like to fix everything. And so I've had to shift my focus a little bit. And it's definitely a work in progress. So making sure I exercise, making sure I eat well, making sure I don't drink too much, making sure I spend time with my friends, take my dogs for a walk, go to a store by myself, those kinds of things. It's really important.
Yeah, great. Thank you so much. I feel like that's definitely a skill that at one point we're all going to have to, face and get to know a little bit more.
Yeah.
Our next question is, did you feel prepared coming out of PA school?
I felt prepared. My first job was in internal medicine. I felt really prepared for that. Part of the reason was because I did a rotation there too, and then I took a job there. But I felt good, going into that. Huge learning curve still. You're on your own. It's totally different. Like you're the one writing the assessment and plan, and I doing it. And so it's definitely a harder transition. But I did feel prepared. I wouldn't say, oh, I felt great and I went out, it took me about, I would say 3 to 4 months to feel like I could do this. Like, yeah, I got it. And then by 6 months I was like, I'm good, and so that kind of thing. So, and you're constantly learning and you're constantly figuring things out, but I would say that I was as prepared as I could have been.
Our next question is a little sad. We know that in oncology, there is a large percentage of folks who end up not beating the cancer. How do you deal with the emotional side of your specialty?
Yeah, so that's also part of the reason I decided to go part-time, because, seeing patients that many days a week for that many years is can be challenging. And finding a positive outlet for myself was really, really important to me. So I have learned over the years how to create sort of I call it a screen. So it's not a wall. It's not, like I don't block myself off from feeling emotions for other people, or getting connected to them, or really feeling sad or feeling emotional about them. I just try to keep it in perspective and what I am able to do, for these people. So, today I had to go over to the ICU and tell a patient that, he should think about changing his code status to do not resuscitate, do not intubate, because he's not well and he's not going to do well. And it's a conversation I don't love to have, but at the same time, like I really want the patient and their family to be prepared, for what is coming next. And I have to gauge how I talk to people based on how they are. So some people want to know everything and other people don't, and other people want you to be super blunt and other people don't. And so I try to do that as well. And when I get emotional, or I get sad, I let myself get emotional and sad. And the best thing that I can do in that situation is talk to the people that have gone through it with me. So the nurses, the doctors, the family members, and they really appreciate that. I think too, though, that I used to do this, and it was the breaking point. If I put myself in the shoes of the patient or the family member, I'm a goner. I have to, like I am Waterworks. I have to remain the provider. And so, and think to myself, if this was my father, what would I want my provider to say to me? And so instead of putting myself on the other side and being in the patient or the family member's situation, which is what I did early on and got upset, is now I kind of flip it and say, what would I want someone to say to me right now? And I feel like that makes it a little bit more reasonable for me. It's never going to be an easy thing, right? But you get used to sort of saying what you need to say in a way that comes across clear and comfortable for patients, and allowing yourself to then come out of the room and have that moment, take a moment, regroup yourself. Some are going to hurt more than others, and that's just going to the way it's going to be. But at the end of the day, you know, for every person that dies, there's another person that I've helped. And then also getting to know that person and their life, even if it's for a really short time, can make a huge impact on your life and remind you why you should live your life not in fear. So.
Yeah, wow, that's beautiful. I can't imagine being in that position. Our next question for you today, when you first diagnose a patient with cancer, how do you determine how long they have to live, or if it's terminal, versus whether it's treatable?
So the staging really depends, and really will guide that for you. Staging, and then also the histology, so the type of cancer that it is, where it is, the staging makes a big difference, and that's why we have staging systems. And then seeing how patients respond to therapy. So most stage 4 cancers are not curable, with the exception of head and neck cancer, because the way they stage it is different. So you can have a stage 4 head and neck cancer, but it's still localized to your neck and it can be treated with chemo and radiation. Or if you have a stage 4 lung cancer, technically not curable, but treatable. Okay. And breast cancer, for example, metastatic breast cancer, maybe not curable, but treatable for like a really long time. Like some patients with metastatic breast cancer live for 10 years. So, you know, these are becoming more like chronic illnesses, rather than, you know, cure, not cure, you know, kind of stuff. For lung cancer specifically, when I first started, average life expectancy, 10 months, period, 10 to 12 months. Regardless, if you were stage 4, your average life expectancy was 12 months. And now I have patients that have been off therapy, on therapy, off therapy 2, 3, 5 years. With the addition of immunotherapy has changed the landscape of cancer care, period. And, you know, basically 20 new drugs for lung cancer in like 2 years, targeted therapies, immunotherapies, insanity. Okay. So we definitely have patients living a lot longer than they used to. And so it really depends on the type of the cancer, the stage of the cancer, and what modalities you can use. There are some patients with metastatic lung cancer that we have cured, that had one spot in their brain, one spot in their lung. They had surgery, radiation, bam, done. But that's technically stage 4. So there, you know, the cases are very different. Then on the other flip side, you can have some very aggressive cancers. So ones that even if you throw your best treatment at them, it's not going to matter. And those are the ones that, you know, really we need to understand a little bit more, and why they don't respond to things, and the basic science, and, you know, all that kind of stuff.
Okay, we have a question in the chat. Why is pancreatic cancer so hard to detect?
Yeah. So pancreatic cancer is a challenge because typically patients don't present until a little bit later when they have symptoms. And by the time they have symptoms, it's usually locally advanced. So that's number one. Number two, our imaging is not perfect. So, you know, CT scans and things like that are great, and they can help, and you can, but there have been pancreatic cancer patients that I would take care of with the physician I used to work UGI with, where their scan looks fine, but they're getting worse. And you know the cancer is progressing, but you can't see it on a scan. You know, I think we're limited in our ability to image certain things. And while there are new imaging modalities coming out and things like that, and you can use MRCPs and ERCPs and these different things to try and get a look at the pancreas, none of them is perfect. It's in a very difficult place in the body, you know, in the abdomen. And unless you kind of open it up and go in there, it's kind of hard to see. There's no good screening tool for pancreatic cancer. That's another problem. We don't have a blood test. We don't have like a specific scan. And so that's really why it's hard to detect and it's hard to treat, and it's hard to treat and it's hard to cure because typically patients present late in the game. And once it's grown beyond the small area of the pancreas, if you cannot have surgery, it's a very aggressive cancer and just doesn't respond well to certain treatments. So, but yeah, we don't have a good preventative measure. We don't have a good screening tool.
Definitely. We have a question about mental health for your patients. So how do you help your patients deal, with different mental health things as they go through dealing with their cancers?
Yeah, so every patient handles their cancer differently. Some patients are in complete denial. Other patients want to know every single thing and are obsessed. Some patients are somewhere in between. Almost all of them at one point or another have some kind of breakdown, or it's not breakdown, but sort of realization that this is out of their control. Everybody, people inherently like to control things. And so we have behavioral health services and psychiatry. So first we'll send them to behavioral health. And that's usually psychologists that specifically deal with cancer patients in different modalities, as well as just general psychiatry as well. We also have palliative care that does a lot of coping strategies. So even if you're not, even if you have a curable cancer, they do a lot of counseling with patients and advanced directives and, things like that to make people feel a little bit more comfortable, a little bit more prepared. But behavioral therapy is very helpful. And then also if they're interested in like support groups and stuff like that, we can give them a list and referrals. Sometimes we'll have patients that will agree to connect with another patient, and tell them their experience, and see how they can. I've had, a couple of people do that. Some patients meet out in the waiting room, become best friends. So, it's kind of crazy, but there's a lot of different people and a lot of different ways we try to make sure that they're getting the services they need.
Awesome. What tips do you have for students who are starting to apply to PA schools right now during the pandemic?
So, I think this year, this coming cycle in 2021 is going to be a little bit of a different ball game. So I think that a lot of people that applied in 2020, that's right when the pandemic hit. And a lot of people had stuff done already, like they had shadowing, they had their hours. Whereas the people this year that are applying next year were super impacted. I mean, I'm not saying that the people in 2020 were not, because they were, but I feel like really next year's cohort, I think, the difficulties with shadowing, people losing their patient care jobs, finding new ones, getting letters of recommendation, all those, finishing your classes online, doing labs online, having to take the GRE at home. Hell no. Okay. So it's been a rough year. So what I would say is that if you're preparing to go into this cycle, realize that you've done the best you can do in the circumstances that we have. They have added a COVID essay. They added it for last year, and I'm pretty sure it'll be there for this year, saying how COVID has impacted your pathway to PA school. I think that there are opportunities to, if you feel that there are deficiencies in your application, there are ways to talk about that in different areas. But at the same time, I would not spend time talking about what you don't have. I would spend time talking about what you do have and all the wonderful things that you have done, not what you haven't been able to do. And so think about the things that you have been able to do. Virtual shadowing, if you've taken online classes, if what have those experiences actually given to you, right? So while virtual shadowing can't replace in-person shadowing, maybe you've gotten a lot of different perspectives from a lot of different PAs and a lot of different specialties, or doctors or nurses or whoever. And you're like, oh my God, I've seen all these different people talk about their professions, and now I really know PA is for me. So even if, or maybe MD is for me, right? So I think, focusing on what you do have is probably more important and going to be more helpful than focusing on what you don't or what you lack. Now, with that being said, you're obviously going to continue to try and get those opportunities and improve on the things you're lacking, which is wonderful. But at the same time, I think a lot of people are very, very focused on what they don't have rather than what they do. How does online courses help you? Well, you now know how to take online labs. You know how to navigate Zoom. You know how to deal with professors over virtual learning. Why is that important? Because when you start PA school, you have no idea what this is going to look like in pandemic times. It could be perfect and you're all back in person, but it may not be. So focus on what you actually have. Get started on your application, start writing your personal statement, and, and really set a good timeline for yourself right now. Because I'm telling you, once the holidays hit and January comes, it's like this. Because February is a short month, March flies by, and then it's time to apply, in April, May. And so really setting yourself up a good timeline right now, start writing down all the things you do have, keeping track of everything, and getting yourself as ready as possible to go into the next cycle.
Wow, thank you so much. I hope all of my pre-PA students wrote that down. It's going to be coming up. So as a healthcare professional, what do you wish was different about the healthcare system?
Oh, that's hard. I wish it was easier, like to navigate for patients. So like, I can't okay, patient comes in. I'm like, oh, you have abdominal pain. You don't look good. I need to get a CAT scan. Oh, well, we have to get authorization first. What kind of insurance do they have? Can they get it today? No, they take 3 days, or you have to get a prior authorization. I'm like, can't they just go? Like, they wouldn't have to go to the hospital now, because now you have to go to the ER because that's the only way it'll get paid for. And, those kinds of things that I feel like make it hard for patients to navigate a lot of the health systems. And if you don't have insurance, it's even harder. So I just wish that it was a little bit more flexible in terms of being able to order things and get things done that you feel are good for your, important for your patients in a timely manner that doesn't take 3 weeks. Why is it taking a month and a half to get into dermatology? Like, what is the situation? Who do I have to call? This is ridiculous. Like, if you can see an oncologist in 2 weeks, why can't you see a dermatologist? Like, I'll page whoever I need to page. Like, let's go. Like, this is ridiculous. This person. So those kinds of things, that's the kind of stuff that I wish was a little bit better in the healthcare system. Yeah. And even assistance programs, like trying to get drug assistance and things like that. You got to sign over your life. You got to hand over your W-2s. You got to do everything. And, for patients that can't pay, and it just takes time. It's cumbersome. And I just wish it was easier.
No, definitely 1,000%. Our next question is actually regarding your business. Can you talk a little bit about the counseling and one-on-one services that you offer from your website?
Sure. So basically, I started this business because I was looking for a positive outlet to help other people outside of oncology. So I love oncology, but as I said, and as you guys pointed out, it can be emotionally draining. It can be challenging. And I wanted something that was helping people in a more positive light. And when I started posting on social media about wellness and health, keeping healthy and blah, 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 most people didn't care. They just wanted to know I was a PA and asked me a lot of questions about being a PA and becoming a PA. And I started talking to a lot of different people, and I helped a couple of research coordinators get into PA school that worked with me. And I'm like, ooh, this is kind of fun. Like, I like this. This is like, and so I just started saying, like, if you need help, like, I'm here, I'll talk to you about it, because there was nobody in my family in medicine. No one, zero zip zilch. I decided, 2 years after I graduated, my parents like, what are you doing? You have a college degree. You're going to go be a nurse assistant for like $6 an hour, like at the time, where like everybody else has been working for 3 years and get bonuses and cars and, all that stuff. And so I kind of know what that's like to go through without anybody to help you. And so I basically said, I don't want people to feel that way. And so basically when I get on a counseling session, it's really about what you want to use it for. What is it that you need help with? I have people that come on that are like in college, freshman, sophomore year, and they're like, okay, how do I plan this out? If I want to go straight through without a gap year, how do I plan this out? Here's my GPA. What can I do to make it better? I have people that have low GPAs that are like, how can I fix this problem? I have people that just want reassurance that they're on the right path. I have people that need somebody to make, just kind of air it out and just be like, is this the right thing? Is this the right thing for me? Do I like it? What should I do? So the counseling session is really customizable to what you need. And I find that, there are some basic questions that everybody likes to have answered. But it's really, I have a whole gamut of different people that come to talk to me. It's 30 minutes virtual, just like this. You and I are talking to each other. You go on the website, you book the appointment, you have to fill out a form so I can get to know a little bit about you, where you found me, that kind of stuff. And then what you hope to gain, from the session, so we can really get started and focus on that when we get on the call. And then we do 30 minutes and then, go from there. So, and it's really wonderful. And I love to be able to have I have a lot of repeat clients. So like if they come for a counseling session, they come back for their personal statement review. And they come back for their CASPA review or their mock-in review. And that makes me happy. And I have some big packages and things that people will do. So, so it's really somebody to be with you every step of the way. I brought on another coach this year. She's unbelievable. She has her MPH. And so Emily and I really feel that my goal for my business and the Posh PA, or the Posh PAs, is to have it be a very personalized service, so that if you're getting a personal statement review, you're talking to somebody like face to face. You don't just send me your essay and like I send you back edits. Like that does not fly for me. So I really feel like I want to get to know you. I want to know what you're looking for, what your point is. And that's why I love doing, the big package, the journey with Michele and the Posh PAs, because those people I help from start to finish. And they get my cell phone number and everything. So like they are like in like Flynn. And when they get in, it's just so exciting. And it's just really rewarding to help people get to where they want to go. And if they don't get in, that's okay. We regroup and, start again, see what we can do better. Yeah, so that's basically an overview. And again, I also like to focus a lot on wellness, your mental wellness, your confidence level. So it's not just about what you're doing for PA school. It's also, what are you going to do to prepare yourself mentally and physically for what is to come.
Thank you. Do you have any last minute advices for our pre-health students or pre-PA students?
Well, all pre-health students, I think, you guys you just do the best you can to explore your different opportunities, explore what profession might be the best for you. If I could give you any advice, if you're early on in college, do your best to try and do as well as you can academically, because I see a lot of people overcommitting in their freshman year and sophomore year, and their grades suffer. You have to remember that academically, that's going to be one of the strongest things, that will help you in the future. Yes, getting experience and research and teaching and all extracurriculars, so important, but your number one priority needs to be your academics, and then mapping out something that's realistic for you, for your future and your timeline. And at the same time, really, really staying in your own lane. And I can't say that enough. I just tell people tunnel vision, focus on your goals and where you are, not where everybody else is. Everybody's a different applicant. And regardless of the school that you're going to, whether it's medical school or PA school or nursing school, you know, it can really screw up your focus and take you on a rabbit hole of bad thoughts that you don't need in your life. Also, surround yourself with positive people and only positive people. Anybody that's bringing negative energy into your space needs to go. You know, make sure that you're doing the best you can to take care of your mental health and your physical health as well. It's easy to have that all slide down the back burner when you're focused on your future career and everything else. So really important things.
Great. Well, thank you so much. This was an honor to host you today. For all of my students, thank you all for joining us. Don't forget to head over to both of our websites. Raphael just put Michele Neskey's website in the chat for all of you who are interested in her program. We have our website. Please feel free to comment on the talk. Please give us any feedback. Let us know if anything said to you today resonated with you, any really big key takeaways that you have, and just any feedback in general. We love hearing back from you all.
Thank you so much. This was fun.
Our next announcement is if you guys are interested in joining our student team, we are currently taking applications. This is actually November 16th. We launched on September 16th. So this is our officially 2 months of pre-health shadowing. So thank you all for helping make this possible. We really appreciate your support. Continue to repost, continue to share with your school. And so all of the students that are interested in going into the healthcare field are able to have that opportunity. If you feel as though you don't have enough time right now to commit as a team member, we also have leadership positions available. This is awesome because it's 100% remote. It's on your own time, on your own schedule, and you can work as many or as little hours as you want depending on your workload. So definitely go ahead and check that out. The link is down here at the bottom, and you can find it on our website. Our spotlight student of the session is Kate P. Kate was able to attend our last session with Dr. Keith Stein and was able to participate in our Instagram challenge. So congratulations. Be sure to follow us on Instagram all. We post a lot of updates for our next speakers, as well as other free resources and other programs that are doing similar things, because we know how difficult it is to find different shadowing opportunities, and maybe getting 2 hours a week isn't getting you to your goal that you need. And so, you know, we understand that, and we try to promote everything that we see so that we can ensure you guys are getting what you need. So this is our Instagram challenge for you all today. If you head over to our page, you can find Michele Neskey's post and go ahead and comment her last name, letter by letter, without any interruptions, and get it in the correct order. Those of you who are able to do that, we will pick a student, and that will be our student spotlight of the session. And so good luck. It's really challenging, so I challenge you all to try it out. So yeah.
I should have given you my whole name. It's really Tafaro Nesskey. That would have been really screwed you all up. It's like
on our website, you will be able to go to Michele Neskey's profile page and click free take this course to the right of her picture. Once you're in there, you will get 15 minutes to take the quiz, and there's 10 questions. These questions aren't meant to be difficult, but rather to show that you were actively participating and taking good notes. Once you finish that and you pass with a score of 70% or higher, you will be able to get your certificate. However, you will only get your certificate if you click Finish Course on the main page. If you do not click Finish Course, you will not receive your certificate and it will not show up in your profile. So just make sure that you guys go back and make sure that you click it if it's not showing up. If you guys experience any issues or have any questions, feel free to email us at info@prehealthshadowing.com, and we'll get back to you as soon as possible. So that concludes our shadowing session for today. Thank you all again for coming, and I hope to see you on Thursday.